Testing 1 2 1 2 test 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 1 2.
All right, I know everybody's kind of filing in, but we'll go ahead and get started. My name is Trent Howard. I'm a cardiothoracic and vascular surgeon here at St. Vincent East. I was asked to talk about something related to my area of expertise, so to speak. So I thought, the esophagus is something a lot of people don't always have intimate knowledge about. It's not something you deal with a whole lot. It is a little bit of a dry topic, so I'll kind of lead with that. But what I'm not going to do is talk about a bunch of updated research and break down papers and those kinds of things. We're going to talk about the esophagus, things that, from a surgeon's perspective, things that we see, things that we look at, things that are important to us, and I'll answer any questions at any time. I'll also preface this with the fact that I have about a middle school level of proficiency with computers, so this is a very simple, straightforward, no frills lecture. So I have no disclosures. We'll talk a little bit about the anatomy of the esophagus, which is kind of a unique organ in itself, and some of the challenges that comes along with that. Some of the motility disorders, we'll talk about the anti-reflux surgery, paraesophageal hernias, esophageal cancer, and finally esophageal emergencies. I had a career before I was a doctor. I was a paramedic, so emergencies are still kind of those things that get your hearts pumping a little bit. I know anybody that has ever worked in the ER or any place understands that. So some of the unique things about the anatomy of the esophagus, you see, do I have a pointer here? Is there a pointer at all on this? On this? The red button. So you see, there's quite an extensive lymphatic and nervous anatomy associated with the esophagus. It also has no serosa, and the serosa is just that outer connective tissue type layer. So two problems that causes: without a serosa, it doesn't repair well. It tears easily. It doesn't take sutures very well, so it's a difficult organ to repair. And that extensive lymphatic network means that cancer spreads really easily in the esophagus and really rapidly sometimes. And I'll talk a little bit more about that when we get to the esophageal cancer part, but just a couple of the things that are associated with the uniqueness of the anatomy of the esophagus. Again, you see on the right side that the esophagus gets its blood supply from multiple places. It's very segmental arterial anatomy, comes from multiple areas, and especially directly off the aorta. And so oftentimes when you're doing an esophagectomy, I prefer to do transhiatal, which is kind of a blind mediastinal dissection. You can cause some bleeding just from those branches coming right off the aorta. On the left side, you see the normal length of the anatomy, and most adults is about 38 to 40 centimeters from the incisors to the diaphragm and the lower esophageal sphincter. Three places that are kind of constricted is that upper esophageal sphincter at about 16 centimeters, where it goes behind the right mainstem bronchus at about 23 centimeters, and again at the diaphragm and the lower esophageal sphincter. So those are the places that things can kind of get caught. So we'll move on to some motility disorders, primary and secondary disorders. I'm not going to talk about the secondary disorders. That's a whole lecture in itself. But the primary esophageal motility disorders are things that you hear about and read about in textbooks, like achalasia, hypertensive lower esophageal sphincter, the Nutcracker esophagus, and esophageal diverticulum. So achalasia, thankfully, is a pretty rare disease, which also makes it difficult to know where this actually comes from. Nobody really knows. There's a lot of theories out there. Is it autoimmune? Is it infectious? How does this happen? But we don't really know. We do know there's loss of ganglion cells, and some of the diagnostic criteria with achalasia is that aperistalsis of the esophagus, it just stops working. It doesn't do anything, just lays there and doesn't do anything. And you get failure to relax of the lower esophageal sphincter, which is also a result of loss of nervous control. The workup for this is usually a barium swallow and EGD, and I have some pictures of those in the next slide, I think. There's kind of a treatment progression with achalasia. Like most of these things, calcium channel blockers and nitrates to kind of help relax that lower esophageal sphincter. Botox, same thing with the lower esophageal sphincter, and balloon dilation. Failure of these less invasive approaches takes you to surgery, which is things like the Heller myotomy. A POEM is kind of a newer technology. It's a per-oral endoscopic myotomy. And I have a little picture of that as well. And some of these people actually, long-term disease progression, they wind up needing an esophagectomy for this. So on the left, that's pretty classic, what we call the bird's beak deformity. That's on all the tests and all the board exams. What is this? That's achalasia. But that being said, the reason that you need to do an EGD on these people with achalasia is to rule out pseudoachalasia, which is a big mass sitting down at the lower esophageal sphincter. So part of the workup for achalasia requires an EGD. On the right side, you see these are the people that really get in trouble and eventually need an esophagectomy. That's called a mega esophagus. It's full of everything. It's just full of fluid. It's full of secretions, oral secretions, totally incapable of doing anything. And these are the people that wind up with aspiration pneumonia recurrently. Can't tolerate any kind of oral intake because it doesn't go anywhere. And these are the people that wind up, again, needing esophagectomies. This is kind of an illustration of what hilar myotomy. You actually have to come down a little bit farther on the stomach, but you understand the concept there is basically you cut through that lower esophageal sphincter because it won't relax and it allows food to pass through. Now what you do by doing that is you cause reflux. There's no anti-reflux mechanism, and the same thing with Botox and balloon dilation, all those issues. You create a new problem to solve this problem oftentimes. So this is what I was talking about, the poem. You see the scope coming down, you make a mucosotomy, you get submucosal, and you dissect down to the lower esophageal sphincter, and you actually use cautery to cut through the muscle layers of that lower esophageal sphincter. You kind of open up the esophagus to the mediastinum by doing that, so you have to be careful by doing that. And then once you're done, you come back up to where you made your mucosotomy, and you put some clips on there to make it watertight. Again, it's kind of a newer technology, mostly in the university type settings because there's not an ICD code for this still, so you don't get paid for it. So it's not going to happen in a lot of different places, but that's coming. It's kind of a less invasive way. It doesn't necessarily involve laparoscopic surgery or laparotomy to do a hilar. Hypertensive lower esophageal sphincter. Again, we don't know why this happens. Nobody really knows. Some ideas out there, but nobody's really proven that. Treatment is often the same as with achalasia, but it's usually more successful because you still have an esophagus that works. The lower esophageal sphincter just won't relax. So these are the people that are successfully treated with hilar myotomies or with POEMs or Botox or balloon dilation or whatever, the treatment that they wind up receiving. And again, you see a high pressure at the lower esophageal sphincter, and it fails to relax. It doesn't relax completely, and that's where these people have their problems. The Nutcracker Esophagus, goes by a couple different names: Nutcracker, the jackhammer, the corkscrew esophagus. Again, nobody knows why this happens. The treatment is the same, but it's also least successful. And if you see this picture right here, you know why this is not very successful treatment. Sure, you can do a myotomy at the lower esophageal sphincter, but what are you going to do with the rest of this stuff here? So these are the people that unfortunately oftentimes wind up either long-term chronic complications associated with this, or they wind up with an esophagectomy. So we'll keep moving on. Esophageal diverticulum. I told you there's three places really in the esophagus that things can kind of get stuck. That upper esophageal sphincter, a place called Killian's Triangle, where you get this little Zinker's diverticulum. This is usually, I can treat this through a neck incision, but usually the ear, nose, and throat guys treat this with just a stapler through the neck. And they staple the neck of that diverticulum, you open it up wide, and things don't get stuck in there anymore. If I do it, I go through the neck, and I either staple off that diverticulum or I pexy it up so that things drain like they're supposed to. Those mid-esophageal diverticuli are called traction diverticuli, and so these are the people that histoplasmosis or some kind of fibrosing mediastinitis attaches scars to the esophagus, and as the esophagus tries to peristalse, it just keeps pulling and pulling and pulling on those muscles until it finally gets weak, and you get this diverticulum in that area. Down at the lower part of the esophagus above the diaphragm are these Poljan diverticulums. Oftentimes these are the people that have that hypertensive lower esophageal sphincter. Well, they just don't relax very well, and so the esophagus is pushing and pushing and pushing against this sphincter all the time. And you get an area that's weak in the wall, and it causes a diverticulum. I'll talk about how to treat that. I've actually got a picture of one here in just a few minutes. Questions so far? I know I'm moving kind of quick. All right. GERD, this is, you can take this from any textbook that you read about reflux disease, the typical symptoms and atypical symptoms. Everybody knows about the reflux and the dysphagia and the heartburn. maybe not everybody understands the asthma, the cough, the hoarseness, tooth decay, recurrent ear infections, all these things that are caused by this nighttime recurrent reflux that people don't even realize that they're actually having esophageal reflux. Three important pieces of information in the workup and treatment planning for reflux disease is an EGD, manometry, and 24-hour pH monitoring. So an EGD, just so you can see what's going on in that lower esophageal sphincter, make sure there's no Barrett's esophagus, make sure there's no masses down there. Manometry, so that you know the function of the esophagus and if it's capable of tolerating the surgical treatment. And 24-hour pH monitoring is to document that, yes, this is reflux disease and it needs to be treated appropriately. Lifestyle changes and pharmacotherapy, weight loss is often not very successful. A lot of people with reflux disease are obese or morbidly obese, and that causes a reflux disease, so weight loss will help those people if they can do that. Elevate the head of the bed, avoiding 4 really important foods to most people: alcohol, caffeine, chocolate, maybe peppermint. Avoid food within 3 hours of bedtime, which is almost impossible especially for me or anybody else I know. Small, frequent meals. Who has time to do that, honestly, especially with our lifestyle? If I took a poll, probably half the people in here or more have reflux disease. Pharmacotherapy is, the H2 blockers, PPIs is my drug of choice personally. Prokinetics and antacids. Again, this is a common disease with a lot of different causes. And to treat this, again, it's kind of a stepwise approach, the least invasive to most invasive. So lifestyle changes in pharmacotherapy first. But we're talking about surgery, so who gets surgery and why do you do surgery? Well, if you've done all those lifestyle changes and you've done the medicines and you still have uncontrolled disease, uncontrolled symptoms, complications associated with it, these people are indicated for surgery. Young patients, so the little lady in your office who's 75, 80 years old, has a little reflux occasionally, does okay with over-the-counter medicine, she's fine. But you have the 25-year-old lady who comes in your office and she has asthma because of it. None of the medicines work. She's done all the lifestyle changes. Her chance of being able to treat this medically for the rest of her life is pretty low, so she would be indicated for surgery. Barrett's esophagus and extraesophageal manifestations, these are people with complications associated with this. Barrett's is kind of a precursor to esophageal cancer, which is it's a bad player. And these extraesophageal manifestations are things, like I said before, with asthma and recurrent ear infections and tooth decay and those types of things. So there are a few surgical options. I got a picture of the Nissen fundoplication. There are some other wraps out there. The Nissen is just a 360-degree wrap of the stomach around the lower esophagus. The Linx System, which some general surgeons may be using. I don't know if anybody here is using that or not. That's kind of a specialized system, and I'll show that to you. And the Belsey Mark IV is a fundoplication through the chest. So this is a Nissen. And just, the fundus of the stomach wrapped around that lower esophageal sphincter, lower portion of the esophagus. It kind of helps recreate the 3 anti-reflux mechanisms. One is that lower esophageal sphincter being able to function and work properly. Next is an appropriate amount of intra-abdominal esophagus. So abdominal pressure and contraction of the diaphragm is also part of that anti-reflux mechanism. And then anatomically, there's a kind of an acute angle at this lower esophageal sphincter called the angle of His. So those are the 3 important mechanical portions of the anti-reflux mechanism of the stomach that a normal functioning esophagus has that you try to recreate with the Nissen. This is a picture of the Linx System. So this is really, it's magnetic beads, essentially, that you place around the lower esophageal sphincter. Different sizes based on the size of the person, their body habitus, but when they try to swallow, the beads open up even though they're magnetic to kind of help the food pass. Once the food passes, those beads with the magnetic part of it contract back and keep things from refluxing back. This is the Belsey Mark IV. So it looks like kind of a complicated fundoplication, kind of a complicated procedure. But once you understand how it works, it's really not that difficult. It's just basically a 2-layer fundoplication. And I'm going to give you a little history lesson here. You'll never see something like this happen again in history of medicine. Anybody that has trained in a university setting or people that write papers and do research. You know that the first new thing that comes along and the first new idea, first thing they want to do is present it at a conference or write a paper or get it published. Dr. Belsey spent his entire career, and the reason it's called the Mark IV is because it was the third improvement on his first surgery. Spent his entire career on anti-reflux surgery, and when he published the paper on this Belsey Mark IV, he had decades of research to back him up. Nobody knew he was doing this except him and the people he was operating on. He didn't go to any international conferences to present, hey, I got this new idea. He had good hard data with decades worth of data to back him up on what he was doing and show this was a good procedure. So you'll never see something like this again ever in the history of medicine just because of the environment that we work in anymore. But really it's essentially it's just a two-layer imbrication of the lower esophageal sphincter, attaching it to the diaphragm and closing the diaphragmatic hiatus posteriorly. Sorry, how do I go back? All right, so who would do this? I mean, this is a thoracotomy. It's kind of a big surgery. It's a big deal, especially now that we have this laparoscopic Nissen and 3 or 4 reports, and people go home in a couple of days. So people that really need the Belsey Mark IV are people that have had Nissens that have failed, sometimes multiple times, or people that have had a significant history of intra-abdominal surgery, and trying to do a Nissen would be complicated and morbid for them. People with impaired esophageal motility, it's not a 360-degree wrap, it's a 270-degree wrap. So people that have motility disorders, you can't do a 360-degree wrap because there's nothing to push things through that wrap. So the 270-degree wrap allows things to go through that lower esophageal sphincter, but still maintain some integrity of that. Incarcerated gastric volvulus, we'll talk about gastric volvulus specifically toward the end of the lecture, but basically when the stomach gets up in the chest and flips back on itself, especially if there's any kind of chronic component to it, that's hard to pull back down through the stomach without damaging the actual organ itself. So going through the chest is often the safer approach. And people with a foreshortened esophagus, there's some things you can do in the abdomen to lengthen the esophagus. I told you about the 3 parts of the anti-reflux mechanism, the mechanical portion of it, but oftentimes if the 80-year-old lady who's had this large paraesophageal hernia for 40 years, and most of her stomach's been sitting in her chest, her esophagus is going to be shortened. It's going to be contracted down and going to be shortened, and trying to do that through the abdomen is going to be nearly impossible. I mentioned already some paraesophageal hernias. There's 4 types. Type 1 is the sliding hernia. This is where and I've got some pictures, so you don't have to just listen to me. But the gastroesophageal junction kind of slides back and forth above the diaphragm and below the diaphragm. The true paraesophageal hernia is the GE junction is where it's supposed to be, and things are actually herniating beside the stomach and beside the esophagus up into the chest. Mixed is a combination of those two, and then type 4 is where you have other abdominal contents. That could be colon, it could be spleen, it could be tail of the pancreas, and anything can kind of get up in the chest if that diaphragmatic hiatus is large enough. So there's the normal anatomy of the stomach and the esophagus where it sits. The type 1, like I said, this GE junction is above the level of the diaphragm. Type 2 is really the true paraesophageal hernia, where there's something beside the esophagus herniating into the chest. Type 3 is the mixed, and then here you see type 4 with spleen and colon and gastric volvulus all up into the chest. So when we repair these surgically, we have a few things that we have to do. Number one, obviously, you want to reduce the hernia and all the contents of the hernia back into the abdomen where it belongs. You have to excise the hernia sac, because if you don't take out that hernia sac, it just gives a way for things to slide back up into the chest again. Intra-abdominal length of the esophagus of 3 to 4 centimeters. Again, like I said, this is the part of the anti-reflux mechanism. It also helps to decrease the risk of recurrence. And then you have to repair the hiatal defect. And how you do that is kind of surgeon dependent. Several different ways to do that, and put a bunch of surgeons together, we would all argue about the best way to do it, but you do have to repair that hiatal defect and prevent reherniation and reflux. So oftentimes these people get a wrap of some kind, whether it's the Belsey wrap or the Nissen wrap or whatever it is, to prevent reflux, and that also helps to keep things from reherniating back into the chest. So SAGES is an organization. They're kind of like the minimally invasive abdominal organ surgical society, and they published some guidelines several years ago. And basically they said that type 1 hernia in the absence of reflux disease, not necessarily a surgical disease at that point. So if you have this sliding hiatal hernia, they don't have any symptoms, just something you watch over time, just make sure they don't have symptoms, they don't have complications associated with it. They don't necessarily need surgery for that. Any symptomatic paraesophageal hernia should be repaired, especially if they have any kind of acute obstructive symptoms or if they have a volvulus, which is stomach up in the chest, flip back on itself. And then the guideline 4 is routine elective repair of completely asymptomatic paraesophageal hernias may not always be indicated. Consideration of surgery should include patient's age and comorbidities. Oftentimes these people with giant paraesophageal hernias are little old ladies, and they're diabetic, they have heart disease, they have kidney disease, they have bad lungs, and so doing kind of a complex surgery on these women may not necessarily be in their best interest. So a little bit of show and tell here. This is a left thoracotomy incision, and it's a big incision, and this is how you do a Belsey. So that's why you try to minimize the number of people that actually get this Belsey, because it's a painful recovery. On the left, this is the fundus of the stomach. I'm getting ready to do the Belsey wrap, and this is a diverticulum, bulging diverticulum at the lower esophageal sphincter that is right there between the two. And you can't really see the wrap because now it's below the diaphragm, but it's not the best picture in the world. I apologize for that. But you can see the suture line there. So I excised the diverticulum with a stapler and then imbricated and oversewed it with suture. So the reason she got the Belsey is she had two different things. Not only did she have the paraesophageal hernia, she also had this diverticulum that was symptomatic and needed to be excised. All right, esophageal cancer. So 17,000 new cases a year, most of them in men. It's the 7th most common cause of death in men. 5-year survival. This is all comers. 5-year survival, 18%. It's a miserable disease. Even early disease has a high recurrence rate. And a lot of people don't, a lot of the thoracic surgeons don't do esophagectomies because not only is it a miserable disease, not only does it come back pretty frequently, but the surgery is quite morbid. 50% complication rate. Pneumonia, leaks, AFib, weight loss, unable to tolerate oral intake. A lot of different issues come up. Until the 1970s, squamous cell carcinoma was the most common type of esophageal cancer in America, and that's because everybody smoked, alcohol, smoking their meats, all those kind of things that are risk factors for squamous cell carcinoma. After the 1970s, adenocarcinoma is the most common type of esophageal cancer in America, and that's due to obesity and reflux. Worldwide, squamous cell carcinoma is still the most common type, but in America, adenocarcinoma is far and above more common than squamous cell carcinoma now. So how do these people present? Unfortunately, oftentimes they present like this, totally unremarkable. Maybe they have occasional reflux, maybe they feel like food gets stuck sometimes and they vomit. So they can have dysphagia. If you start talking about advanced disease, weight loss, bleeding, pain, chronic cough, hoarseness, and these people are the ones that present with locally advanced disease. Workup, I put question marks beside the esophagram because it's not really the gold standard. EGD is the gold standard. You have to see this thing. You have to biopsy this thing. You have to know what's actually going on and where it's at. Because where it's at often determines the surgical approach. Esophageal ultrasounds, EUS, that's part of the staging process. So after you've done the EGD, you biopsy it, it's adenocarcinoma. Now we do the ultrasound to look for how locally advanced it is and if there's any local lymph nodes involved, just kind of help with staging. PET CT, just like with any other cancer, to rule out distant disease. Bronchoscopy, if it's mid-esophageal cancer, which is more likely squamous cell carcinoma, or upper esophageal cancer, again, the squamous cell, that's where you really run into the risk of airway invasion, and airway invasion is contraindication to surgery. So if there's any concern at all, there may be some airway component of it, then a bronchoscopy is indicated. Fortunately, it's a fairly resectable disease. Anything up to stage 3 can be treated either endoscopically or surgically. High-grade dysplasia with Barrett's that can't be treated endoscopically, which often, the gastrointestinal guys are so good with their scopes and their endoscopic treatment. Oftentimes they can treat Barrett's esophagus and high-grade dysplasia and early disease esophageal cancer without an esophagectomy, thankfully for the patients. But any patient who's capable of undergoing resection based on their stage and functional status is a potential candidate for surgery. People who can't have surgery are people with non-regional N2 nodes. You're talking about celiac nodes, supraclavicular nodes, things that indicate that nodal disease is distant from the primary. Invasion of the airway, like I said, or major vascular structures. People with severe comorbidities and distant disease, stage 4 disease is a contraindication of surgery. And people with severe comorbidities, I mean, these, the morbidly obese, the diabetic, the kidney disease, the terrible lungs, the bad heart disease that can't even get their gallbladder out because it's so bad, no way they're going to tolerate an esophagectomy. So we still use the T, N, and M staging for esophageal cancer, and I talked a little bit about the nodes, which aren't quite as important as staging. M, obviously, if there's a metastatic disease, it's stage 4 disease, not surgical. So this is kind of the important thing, is the T stage. So T1A, it's confined to the mucosa. And these are the people that the gastrointestinal guys, through the scope, can often resect this cancer successfully. They can monitor it, active surveillance for months to years afterwards, just to make sure there's no recurrence, and they do a really good job of treating early stage disease. T1B is a little more controversial because now you're in the submucosa, and that's where the lymphatics live. And I already talked about at the beginning of the lecture the extensive lymphatic network of the esophagus and how quickly things can spread. So there are some guys out there that argue T1B you should try doing endoscopic resection and extra close surveillance to make sure there's not a recurrence. There's also a lot of guys out there that argue, like I just said, you're already into the lymphatics, your risk of spreading away from the primary source is significant, and so an esophagectomy should be done. T2, it's in the muscles, T3 in the surrounding tissue of the esophagus. T4A, so if it invades the pleura, the pericardium, diaphragm, peritoneum, all those things can be resected in block. I know the esophagus is a vascular structure, it's not a necessary vascular structure, so if it does invade the esophagus vein, we can resect that in block with it as well. But the T4B, these are the people that are not resectable. It's invading the aorta, it's invading the airway, or a arteriovertebral body. And again, the principles of surgery, the T1A, great, do it through the scope and closely watch them. Anything more than that, you should consider esophagectomy. So the type of resection is often dictated by the location, the available conduit, and patient and surgeon preference. So I have listed 7 different approaches to do an esophagectomy. And that's not all of them. If you know anything about surgery, if there's 7 ways to do the same thing, it means there's not a good way. And it's very surgeon dependent. It's how you're trained. I was trained to do it a certain way. Yeah, I can do it a couple other ways, but I'm trained to do it a certain way, and that's how I'm going to do the best possible resection. Somebody else is trained a different way, and that's going to be their resection of choice. We can argue all day long about the advantages and disadvantages of each approach, and I'll talk about it a little bit, but it's really very surgeon dependent on what type of resection you get. So we usually use the stomach. That's the preferred conduit. It's the easiest to use. You can use the colon. You can also use a portion of jejunum to replace the esophagus. Lymph node dissection is very important. You should get at least 15 nodes. And one of the knocks on the transhiatal is that maybe you don't get so many nodes. So the Ivor-Lewis and the McEwen. The Ivor-Lewis is a abdominal and chest surgery, either open or minimally invasive. Either way, it's Ivor-Lewis resection. The anastomosis of the conduit to the esophagus is in the chest. The McEwen is what we call the 3-hole. So they get abdominal, chest, and a neck incision. The advantages to doing this open is obviously it's an open surgery. You can see what you're doing. It's great for the surgeon. You can actually feel things, get your hands on things. You get a really good lymph node dissection because you can see things really well. The downside is the morbidity associated with the thoracotomy. The chest anastomosis, and that's one of those things, I said is always up for debate. I like my anastomosis in the neck because if it leaks, and 12% of them do, you open that incision and give them some antibiotics, they're fine. Your anastomosis is in the chest and it leaks, now you have an empyema. Now you're back in there cleaning things out. Now they have pneumonia, now they're on antibiotics for weeks at a time. So that's one of the things that the surgeons often debate is where should we put the anastomosis and why. The Ivor-Lewis is not good for upper esophageal cancers. You need a 6 centimeter resection margin of normal tissue, and if it's an upper esophageal cancer and you're doing an Ivor-Lewis, you're not going to get 6 centimeters clear. Transhiatal, this is my approach of choice. I do a small upper midline laparotomy and a left neck incision. It's less morbid because you don't technically go in the chest, even though you're kind of doing a blind mediastinal dissection with your hand. It's good for a tumor at any level. There is some early survival advantage to the transhiatal because you don't do the thoracotomy, you don't go in the chest. Some people say you don't get as many lymph nodes because, again, it's kind of a blind dissection, and I'm putting my hand through the posterior mediastinum, so just kind of freeing things up. So you may not get as many lymph nodes as you would if you were doing it robotically or if you were actually in the chest looking at it. But that's not always true. There's a lot of research out there that says lymph node count is the same. There's some minimally invasive approaches out there that are done either laparoscopically, thoracoscopically, and robotically. There's decreased morbidity, obviously, because it's less invasive with shorter recovery times. But the downside is that it takes a lot longer to do a really big and long operation. There's a steep learning curve. Minimally invasive esophagectomies, the learning curve, and depending on what articles you read, is anywhere from 50 to 100 esophagectomies. Well, if you're doing 10 or 12 a year, you're going to be halfway through your career before you're actually an expert at it. So really kind of a tough learning curve to get really proficient with it. And if you're not at a program like Pittsburgh where they do a couple hundred a year, you're not going to be able to do it very successfully. Minimally invasive is not good for really large tumors, especially if there's invasion of other organs. People with previous abdominal surgery is not necessarily a contraindication, but it certainly makes it a lot more complicated to deal with all the scar tissue and adhesions. Could be difficult to do a lymph node dissection depending on how far you're reaching, especially if you're doing minimally invasive through the abdomen, or if you don't have a usable gastric conduit for whatever reason. I don't think anybody's doing minimally invasive colon interpositions or jejunum interpositions for their esophagectomies. So this anastomosis location, like I said, in the neck, it's more extensive resection because it's an extra incision. You have to stretch the stomach a little farther. If you do transhiatal, you avoid that thoracotomy. There's less reflux because the anastomosis is in the neck instead of down lower. So you still have part of that esophagus that's peristaltic. They can kind of decrease the amount of reflux. And again, like I said, the sequela of an anastomotic leak in the neck versus the chest is pretty significant. The chest, there is a lower leak rate in some studies because you're not stretching that gastric conduit as far as you would if you have to go to the neck. A lower stricture rate because you have a little better blood supply to it. A lower risk of recurrent nerve injury. In the neck, where we get around the esophagus and that tracheoesophageal groove, the recurrent laryngeal nerve lives in that area, so you have to be really careful to not injure that nerve. So if you don't have a neck incision, then you're not going to injure that nerve. If we have time, I'll show you that's like a 4-minute video of a robotic esophagectomy. Questions so far? All right, some more fun stuff. Some emergencies. This is a chicken bone. That's only a small portion of the amount of chicken that was above said chicken bone. I didn't take a picture of the big chunk that was above that. This lady, she was at work, she was in a hurry, took a big bolus of chicken, didn't realize there was a bone in there, came to the ER with an esophageal perforation. We took her to the operating room that night and fixed it. So this is the esophagus in the neck. That's where it got caught, right in the neck, and she had a little perforation right there. Opened it up a little farther, pulled the bone and all the other stuff out of there. I'm sorry, I know everybody just had lunch, but pulled all the other stuff out of there, and a 2-layer closure to fix the esophagus. A little drain for a couple of days, and she did just fine. So Boorhaave's and Mallory-Weiss syndrome is something you see pretty commonly in the ER. These are people that they get, maybe they drank too much the night before, maybe they have some kind of gastrointestinal problem, and they have really forceful vomiting. And now, Mallory-Weiss is just a mucosal tear, and sometimes they'll come to the ER with chest pain, they vomited blood. Everybody gets scared to death when they vomit blood, obviously, as they should, and so they come to the ER, but they're actually very fine. Radiographically, there's no problems other than the underlying condition. They're really doing just fine. And this will heal on its own. There's not really much you need to do about Mallory-Weiss tear. Boorhaave's is a different story. There's actually a full thickness tear of the esophagus. And once you get through that mucosa, I told you there's no cirrhosis, so it's just muscle fibers that open up and things can get through there and leak out into the mediastinum or into the chest. So again, Mallory-Weiss tear, just conservative management, treat the symptoms, treat the underlying problem, not much to do. If you suspect Boorhaave's, and I have some pictures, most people that come to the ER with chest pain or vomiting, they're going to need a chest x-ray. Boorhaave's, you're going to see pneumomediastinum on the chest x-ray. It's immediately going to prompt a chest CT, which is going to show you, a lot more information. How much air is in the mediastinum? Is there any pleural effusions? And if there is a pleural effusion, then you get an esophagram. Thin barium is the safest esophagram to do, or gastrographin, some kind of water-soluble contrast is best. Full barium esophagams, if there actually is a leak and it gets out of the esophagus into the mediastinum and into the chest, it sets up like concrete, so it makes a mess for me to clean up. If it's contained perforation, just a very small hole in the mediastinum, not spread anyplace else, a lot of times these people can be treated just by keeping them NPO and IV antibiotics for several days, repeating the esophagram in a few days and see if it's sealed itself off. If it's really a true perforation, that's an emergency. That's people that go to the operating room in the middle of the night, especially if it presents early, because these are people that have a big hole in their esophagus that has to be fixed. You have to contain the leak. You have to clear out the chest so they don't get an empyema. And again, these are the people that we take to the operating room in the middle of the night. You want to make sure they're appropriately resuscitated, just like any other septic patient. They're really septic, so appropriate IV fluids, IV antibiotics, get them ready for the operating room, the stress of surgery, and then we're taking them to the operating room. Late presentations, so these are people that say, you know what, this has been going on for 4 days, and now I have a fever, and now I'm a little confused. Grandpa's not himself. He's a little confused, kind of out there, and they come to the ER and they have this big left effusion or big right effusion and pneumomediastinum. Oftentimes, these people require a diversion, and when I talk about a diversion, I'm talking about an esophagostomy, so an ostomy in their neck or on their chest, because that can't be fixed until it heals. So these people that are acutely ill, 4 to 5 days out, the esophagus is just kind of like mush in there, and you can't put sutures in that and fix it. So you have to divert everything away from it so it can heal on its own and go back another day and fix it, which is kind of a big deal. Thankfully, we do have some stents. Some patients may be amenable to stenting instead of this diversion, so we don't always have to divert everybody. But again, if there's already an effusion, that's going to have to be cleaned out. So they're going to have to go to the operating room. We have to get everything in their chest cleaned up. So on the left, there's that chest X-ray with the pneumomediastinum. Radiologist calls the ER doctor, says, "Hey, there's pneumomediastinum." Automatically, they're going to get the chest CT, and you see on the right, there's air around the esophagus, there's air around the aorta, all through the mediastinum. This is kind of a contained perforation. That's a big perforation, but it's all contained in the mediastinum. You don't see it's not leaking over into the chest. So these are people that, even though it's pretty close to the lower esophageal sphincter, you may consider stenting these people, or just watching them, treat them conservatively, NPO, IV antibiotics, repeat the esophagram in a couple of days and see if this seals itself off. And if not, then do a stent. This goes to the operating room. There's a big effusion, and it's going to have to be cleaned up. There's probably a big hole in there somewhere. You see all the air around the airway, around the aorta, around the esophagus. So these are the people that wind up in the operating room 1 o'clock in the morning. Esophageal varices is not often a surgical disease, most often treated medically or treating the underlying problem, which could be a liver transplant or whatever. But occasionally you get these people with these massive upper esophageal bleeds. This is not a lecture on portal hypertension as treatment, so I'm not going to get into all that stuff. But just to kind of cover the bases with esophageal varices, you'll make sure there's appropriate resuscitation, IV fluids, blood products. Just because the bleed stops doesn't mean it's not going to recur. The rebleeding rate is pretty significant on esophageal varices, so it still needs to be treated. NG tubes, a little questionable. If you're comfortable putting an NG tube in somebody with varices, you kind of leave that up to you, but you're also putting a tube past a big vessel sitting there in the lower part of the esophagus that has just bled. So you want to make sure that you're perfectly comfortable with doing that and who the patient is. Protect their airway. Obviously, if they're actively bleeding, they may need to be intubated. Shunts, devascularization, and what I mean by that is stapling off the distal esophagus, just a blind stump, just to stop all that portal hypertension of causing these varices. The Blakemore tubes, Minnesota tubes, those are just balloon tubes that you put down the esophagus. You blow up the balloon to try to hold pressure on the area that's bleeding, so hopefully it stops at that point so you can be treated, treat the underlying cause later. Endoscopic treatment. This is another area where the gastrointestinal guys are really good with the scope and going down and doing sclerotherapy and injecting epinephrine and banding varices that are bleeding. And there's a lot of options available to them, and as long as the patient's stable enough to tolerate it, that's certainly better for them. Octreotide and vasopressin, these are vasoconstrictors. They decrease blood flow to the alimentary tract, and so they can kind of help control the bleeding and the rebleeding rate as well. Esophageal foreign bodies. So this is right thoracotomy, lungs decompressed, atelectatic kind of pushed out of the way. This is the esophagus running through the posterior portion of the right chest. You see that little deal right there? That's what that is. This is so this lady had swallowed multiple items, psychiatric, underlying disease, obviously, multiple laparotomies for swallowing things. In the psychiatric ward, University of Iowa Hospital, somebody thought it'd be a good idea to give her some coloring pencils so that she could color a picture. So she promptly grabs this thing and shoves it down her throat and perforates her esophagus. Almost done, y'all. I'm sorry. So gastric volvulus, there's two types. Organoaxial volvulus, you see that the body of the stomach kind of flips up on itself, and the mesoaxial volvulus, where the distal part of the stomach flips up proximally up on itself. And oftentimes the stomach is in the chest. These are big paraesophageal hernias. It can happen in the abdomen, but most of the time these happen in the chest. This causes a closed loop obstruction. Same thing, with large intestine, small intestine, bowel obstructions. Same thing happens to the stomach. So you get this closed loop obstruction, buildup of gas and secretions and air inside the stomach, and you can really get ischemic stomach and perforation. There can be some chronic component to this. Oftentimes people have this chronic intermittent volvulus type obstruction, especially little old ladies. These they come to the ER intermittently with abdominal pain, and they're found to have a gastric volvulus. It's still a surgical entity. We still need to be involved because, like I said, you get this closed loop obstruction, you get ischemic stomach and perforation. You can try some endoscopic decompression. A really good gastrointestinal doctor can sometimes take the EGD scope down there and kind of detorse that thing, but it doesn't keep it from happening again. So if this happens, and they're capable of undergoing repair of the paraesophageal hernia, we still need to fix it, just not emergently. It doesn't need to be at 1 o'clock in the morning. It could be at 7 o'clock in the morning. And again, appropriate resuscitation is required before surgery. These people come in and they're really sick and they're obstructed, and you think their stomach might be ischemic. They're septic, so they need appropriate resuscitation with IV fluids and airway protection and IV antibiotics. And again, like I said, oftentimes these are the little old ladies who are terribly debilitated and comorbid from the nursing home. They come in with gastric volvulus and they're very sick and oftentimes don't survive, something like that. So the principles of repair, again, decompression and reduction, just to decrease the ischemic component of the stomach. Plus minus resection, if there is an ischemic component of the stomach, that has to be resected. You can't leave that. It's not going to all of a sudden survive. It has to go away. And prevention of recurrence, and that could be, to repair the defect, repair the esophageal hernia if they can tolerate it. Sometimes all it takes, or all you can do, if they're sick enough, is just stick a peg tube in. If you can get their stomach back down in their abdomen, you stick a peg tube and stick it to their abdominal wall so it can't volvulize back up into the chest or back on itself again. And fundoplication is part of the paraesophageal hernia repair. Again, if it's somebody who's capable of tolerating that. That was a marathon. Sorry about that. Questions?
You talk a lot about little old ladies. Is this more common in women?
It is. Surprisingly, like I said, these are little 85-year-old ladies who are just tough as nails, and they've had these problems for decades, and they either didn't know about it or they just didn't worry about the fact they were having problems with it, and now their daughter or their granddaughter or their son or somebody is worried about it. They take them to the ER and they find they have all these problems, and oftentimes they're not good surgical candidates because they're old and they're comorbid and they weigh 90 pounds and they just won't tolerate what we need to do to them. Anything else? That's a lot of information. All right. Well, thank you all for your time. I appreciate it.